endodontist. I dedicated the last 30 years of my life practicing endodontics and teaching endodontics, but also confronting myself every day with real life, as you can see in this picture. Further, in 2006, I ended up with my department within a main hospital, so we needed to start confronting ourselves doing regular endodontic treatment in non-regular patients. I mean, those patients who were under some medication because of chronic disease. They were living a good life, but still not really healthy patients. And that added a lot to my experience. And so let's go back to what I want to share with you today. So what are the factors influencing apical periodontitis? We have seen quite a bit of clinics today, especially this last lecture, addressing some of the problems that we have to pursue endodontic success. Because we know also, now I refer to a classic study from the 60s, Belder and Seltzer and Bender, that as scientific evidence accumulate, there is a greater and greater dissonance in both the theory and the practice of endodontists. But of course, these apply to every field in life, because on one hand, you have a cookbook on what to do for a certain circumstance, but on the other hand, you have the results, but it's mostly dependent on how good we are in following the cookbook, but also some minor other factors. Okay, so we will go through the concept of persistent apical periodontitis. We're going to look at host-related factors influencing apical periodontitis. And we're going to go to check the effect of impaired immune system, by this meaning systemic condition of the patient, and also persistent inflammation, which means genetics. And then we finally take a look at the therapeutics adjuncts. What is the feature taken for us? So we know that, to quote Shimon Friedman, my friend and mentor, success of endodontic treatment is related to the prevention and treatment of apical periodontitis. Ideally, we want to address huge lesions. Now we have wonderful ways to check. We can even see the volumes of the lesions, of course, and we can discuss in details on the size of the lesion, its location, and the teeth involved. And of course, following treatment, we want to be able to monitor healing of those lesions to a single millimeter. So this is our everyday endodontics. Unfortunately, we know, and now I am quoting one of the traditional and classic papers of the latest 10 years, which is Dr. Ng study. So we know that under controlled clinical conditions, in the presence of preoperative apical periodontitis, the potential for a favorable outcome for primary, both secondary root canal treatment is in the range of 75 to 80%. Not too bad, but not too good. And interestingly, this is happening since 1956. Why do I say 1956? Because this is the first study, important outcome study, which is Dr. Strindberg's thesis, where many details were controlled to assess the outcome of endodontic treatment. So not much has moved ever since. So what is persistent apical periodontitis? We used to call it failure, but it's more smart to call it persistent apical periodontitis. It is a radiolucent lesion which is associated with a root-filled tooth, a previously treated tooth. The prevalence of evidence of persistent apical periodontitis goes to 41% based on the recent literature. And of course, the factors that are implicated in persistent apical periodontitis are often intraoperatives, of course, inadequate aseptic control, as Dr. Buchanan was showing, missed canals, insufficient instrumentation, basically, and inadequate restoration, basically, bacteria staying in the root canal system. And this is a classic case of my practice. This one was a retreatment case that was sent to me, and honestly, I thought it was looking pretty good, but of course I had to retreat it. Those days it was critical for a denture. And so I retreated it, and I disclosed a total new system, which I wasn't even expecting. So this was the cause of a failure. As we say, this is the most consistent cause of endodontic failure, or if you wish, persistent apical periodontitis. This is why we have a fantastic paper from José Siqueira, very recent, in which they were able to quantify that the volume of an unfilled root canal is significantly associated with the size of the lesion and possibly with the bacterial count. Okay, so no doubt, whenever we have a persistent apical periodontitis, it is very likely that we are missing some portion of a root canal, and this way leaving some infection behind. But what happens in cases like this, huge apical periodontitis? I did a retreatment, forgive me, I did a retreatment. I wasn't able to remove this very large separated instrument right in the curvature of this mesiolingual canal. So I told the patient I would go for surgery. First, I completed the retreatment of the buccolingual canal and the distal canal. And then we waited for surgery. But you see, it healed. Nonetheless, it healed, even though I left part of the canal not instrumented. So there was some tolerance of the system. And we know from this other classic study from Jorge Vera and Dr. Nair that whenever we do a state-of-the-art root canal, if we take a couple of millimeters out of the canal, just instrumented, you will find bacteria and fungi in that area, even if it was a very thoroughly performed root canal treatment. Yet, 85%, 75 to 85% of these cases will heal. So what's the thing? We need to realize that we do a treatment, but after following the treatment or during the treatment, we can have complication not only due to endodontic mishaps like missed canals or broken files, perforation. There could be complication related to other factors. So we can concentrate on what we call the host-related factors in every single field of medicine. And endodontic is a medical branch. Okay, this is a case, this patient came to me telling me that she was sent to my attention because she tended to produce granulomas. And of course, 10, 15 years ago, 20 years ago, when they told me they produced granuloma, I was feeling funny about it because I thought, well, you do not produce granuloma. You simply have root canals that are either not treated or poorly treated. So you need a good root canal treatment. That's all you need. Those days, I didn't have so many years of experience of studying, I guess. So root canal treatment was mostly likely to be an equation. Then you retreat it. You do your best job. It looks much better than it was before, and they're still there. So now my doubt is maybe they're really producing granulomas. So systemic factors that influence apical periodontitis can be related to the immune response of the host or from its pro-inflammatory status. Let's take a look at what's going on, because sometimes the research goes one way and we keep practicing the other way without discussing the finding of research too much. So let's take a look at the impaired immune response. We know that the integrity of a non-specific immune system has an influence on the outcome of endodontic treatment, which may be almost as important as other patient and specifically treatment-related variables. This is a very, very important paper because it's an eye-opening paper. Monica Merending at the University of Zurich a few years ago decided to do a personal outcome study on 200 cases treated by herself or retreated. The point is, the patients were not regular patients. Those were diseased patients. They were like diabetic patient who went through tumors or IBDs, which are inflammatory bowel disease, and so forth. Further, these patients were on heavy drugs like cytostatic drugs or steroidal anti-inflammatory drugs or so. So she evaluated treatment outcome with a very sophisticated statistics, and she found that the odds ratio for the role of the immune system in the outcome of these patients was very close to the quality of root canal treatment, which is accredited as the indicator for a good root canal treatment outcome. Basically, the results suggest that the status of the immune system are almost as important as the technical quality of endodontic treatment for the outcome of endodontic therapy, which makes a lot of sense. We're not all the same. Look at this. This is state-of-the-art root canal treatment on a 78-year-old patient, healthy patient, a little bit of a high blood pressure, nothing more. And you see, it healed pretty fast. It took him 6 months to start a good visible healing, obviously symptom-free. On the other hand, take a look at this 35-year-old diabetic patient. I did a retreatment. General dentist did a second prosthetic rehabilitation without waiting for the tooth to heal. I was worried when I did my first recall, my second recall, 18 months recall. I even told the patient maybe we could do apical surgery so that we forget about the problem. But he said, I'm fine, so I can wait. Well, it took 3 years, but it did heal. He was right. But it took him 3 years rather than 6 months or 1 year. Probably his baseline disease prevented him from healing faster. And these data are easily confirmed by this study, which is the Tennessee study, a study done by Dr. Azim, where he evaluated endodontically treated teeth over multiple follow-up to find predictor factors for treatment outcome. Interestingly, this study is one of the first outcome studies in which patients with medical condition were included, because usually in order to have clear data, the patient with medical conditions are removed from the studies. So in this particular Tennessee study, this patient with medical condition were included in the study, and it was found that age and immune condition as minimum delay. So-called compromised healing group, which included all of these older patient or immune depressed patient, took at least 7 months more than regular patient to heal, if they heal. So basically, we're going to start seeing that immune system does affect the outcome of our treatment, and of course also age in a way. Diabetes is one of the most important indicator of a diseased immune system. In this sense, we have a longitudinal outcome study with a very huge number of cases that was performed by Dr. Fuad in 2003, in which basically they found that patients with diabetes undergoing endodontic treatment, number one, were more at risk for endodontic flare-ups. And number two, they were more likely to fail when you did endodontic treatment on those teeth. The same group, almost 20 years later, performed a second study, again, in a second study on diabetic patients, but in this case, they did a study on type 2 diabetes and the level of control of glycated hemoglobin. And this is an interesting finding. They found, and that was expected, that type 2 diabetes mellitus, together with poorly controlled glycemia, were significantly associated with apical periodontitis. But the use of metformin or statins, or metformin and statins, was associated with lower prevalence of apical periodontitis. So we're starting to see that the disease condition of a patient will slow down its healing its response to apical periodontitis treatment on one hand. But on the other hand, the same patient, if they use metformin or statins, may have a slightly better outcome. And we'll get to this at the end of this lecture. So last but not least, there was a nice review of a literature performed by the Spanish group of Dr. Segura Egea. And they concluded that diabetes is associated with the higher prevalence of apical periodontitis, which puts diabetes as an important preoperative prognostic factor in root canal treatments. In other words, if we're doing root canal treatment in a diabetic patient, we may expect a higher level of failure and post-treatment accidents or inter-treatment accidents. So what did we do? I told you we work in a clinic. So we started looking at our patients because we are within the main hospital. And this is my fantastic research group, fantastic girls. The model that we had were chronic inflammatory autoimmune disease, such as rheumatoid arthritis, Crohn's disease, ulcerative reticulitis, and other rheumatic autoimmune disorders. The common trait of these diseases is that this patient produce an excess of pro-inflammatory cytokines. So this is the story. Those are highly reactive patients. So we did a first study in which we wanted to see the prevalence of apical periodontitis in patients with IBDs or rheumatoid arthritis versus patients without major diseases. We did a thorough dental and endodontic evaluation. We had 110 patients for each group, both male and females. And to make a long story short, we found out that the immune system and medication seem to influence the response to patient to endodontic infection because, of course, those patients had a higher prevalence of apical periodontitis, particularly in women in this case. So now we know that. What about the pro-inflammatory status? Because immune conditions are very well known usually, so you know that you have a patient who has an immune condition, whether it's temporary or it's a permanent condition due to a disease. What about the pro-inflammatory status? Now we know that bacteria initiate the patient inflammatory response, but also that other factors can modulate or amplify that inflammatory response, and it will change its clinical presentation and or also the progression of a disease. Dr. Morsani wrote one of a precursor paper in this sense. In a retrospective case control study, they examined the association with genetic polymorphism in the interleukin-1 beta gene and the cases of apical periodontitis that was not healing. And they identified that there was a specific genotype in the interleukin-1 cluster that was associated with the persistence of apical periodontitis. What does this mean? It means that the patient in which the authors had problem in seeing a good result of their treatment had 2 to 4 times higher reactivity in terms of production of interleukins-1 beta than the other patients. So we're starting to look at a patient that has a tendency to respond with a stronger inflammation to the same pathosis. And it may be more difficult to turn off the switch, to turn off this inflammation. So we're starting to see that also genetic factors from the host that influence its response to inflammation may play a role in the response of the host to endodontic treatment, even if it's a good state-of-the-art endodontic treatment. And if we look at this review, we know that some individuals, when they are challenged by microorganisms, may exhibit a greater immune response, which can lead to persistent apical periodontitis or to a stronger symptomatic apical periodontitis. And we can see that there are polymorphism and also biologic modifiers that influence. So some people have a predisposition to a stronger responsivity to the infective stimulus from the root canal. And that may affect not only the presentation of apical periodontitis, but also its potential to heal in response to the treatment. And this is the last paper from Fouad, which is very recent because it's 2020. In this paper, he confirmed what I just said, and he explains thoroughly the role of genetic polymorphism, gene expression, and epigenetic factors. Now let's go back to the clinics, because after all, we always think in terms of the patient that we are seeing, the lesion that we are treating. If we look at the classic study, again from NG, we see that healing of apical periodontitis can be influenced by a few factors that are preoperatory factor, intraoperatory factor, and post-op. Of course, if you look at the intra-op and post-op, you will see all of the technicalities, okay, like working length patency, absence of perforation and mishaps, and of course, a good coronal restoration. But let's look at the pre-op. Those that do not depend on us, but they depend on how the patient presents himself to us. One of the most important preoperative factors for the prediction of a good outcome of endodontic treatment is the presence of a lesion. If we start our treatment with the apical periodontitis, we have 49% lower odds of success. And you may say, of course, we treat apical periodontitis. Not true. Sometimes we simply treat pulpitis. So we do root canal treatment without apical periodontitis. So now a doubt arises. Do all deep caries develop to apical periodontitis at the same time and with the same intensity? If you look at the basic research, we start to see some results. For example, polymorphism in metalloproteinases and in tissue inhibitors of metalloproteinases support the association of these genes when an increased risk of development of apical periodontitis, given the same condition of root canal infection. So again, a little interference of genetics. One more recent papers. The polymorphism in heat shock proteins may be associated with the development of apical periodontitis from carious lesion. When they compare patients with deep carious lesion, those with this polymorphism were developing apical periodontitis more predictably and faster. So even the development of apical periodontitis depends on the patient, given that he has, of course, an infected deep carious lesion and an infected canal. One more factor, the size of the lesion. We know that the odds of success were found to decrease by 14% for every 1 millimeter increase in the lesion size. Okay, but why is a lesion wider than another lesion? It has been interpreted with a greater diversity of bacteria. We know that, and this may depend also, as we said before, going back to Siqueira, that 1 unit increase in the percentage of unfilled apical volume will lead to larger lesion by 2% increase. So, of course, infection and the importance of infection and the gravity of infection. But also, longer lasting infection are usually driving to larger lesion. And this has been also put in relation with a possible cystic transformation. We know that we may have apical cyst and granuloma, the mostly represented lesions. And usually, as the time goes by, there are more likely opportunities that apical periodontitis will develop into an apical cyst. Also, it has been considered that a so-called true cyst, which is a cyst that has lost any connection with its root canal, may be not responding to root canal treatment because it has lost any possibility of interfering with the treatment. Let's take a look at this case. I did it a few years ago. There was a tooth with apical periodontitis. I did a thorough retreatment. It was getting worse within a year. Great success now. Apicoectomy and retroprep and you see only 6 months later it's already healing. Then we did the biopsy, and it was a cyst. So it's easy to think it was a true cyst. Of course, I didn't know whether it was a true cyst, but we knew it was a full cyst by the semi-serial sectioning that we did in this case. And the case started to heal right after my surgery and right after the lesion was removed, while it didn't heal before. So was that because it was a cyst? Now we need to sit back and think. Is it real thinking that the true cyst might not heal after conventional root canal treatment simply because it is a true cyst? It is a fascinating theory, but what can we think? There is a very nice article by a German group who investigated radicular cysts, granulomas, which are in essence the inflammatory lesions, and the dentigerous cyst, to understand the difference in the inflammatory response in a very sophisticated way. And they came up with the conclusion that development of apical periodontitis into a radicular cyst appears to be associated with a very strong pro-inflammatory state. The development of apical periodontitis into a granuloma had a pro-inflammatory state which was much smaller than the one that influenced the cyst. And of course, going to dentigerous cyst, they didn't have any inflammatory state. So some patients produce a higher inflammatory state, and so they're more likely to have a cystic transformation within their endodontic lesion than others that will stay with a granuloma. So we're starting to move in that direction. And if we look at Ricucci's study, which is another very, very recent study on true cysts, Domenico Ricucci evaluated true cyst and base cyst to see whether it's true that a true cyst could heal with more difficulties compared to a base cyst. And the result of this study is that true cysts do not seem to be independent from the root canal, even if they are completely rounded and close. That the endodontic success rate is not to put in relationship with a cystic lesion. So basically, he's saying that it's not acceptable the concept that the true cyst will heal with more difficulties than a base cyst, but also suggested that there is an individual predisposition to develop a true cyst, for example, because he found that the sisters had a true cyst rather than a base cyst and so forth. So again, a different response to bacterial irritation in different people with different setting for the inflammatory response. And that will influence healing. Again, a higher size, a bigger size of a lesion may mean that larger lesion represent a more exaggerated response, less likely to be affected by treatment protocols. And again, let's take a look at what's going on the other side of our world in the research. If we look at this paper, we see that the interaction between TT genotypes in bone metalloproteinases and RUNX2 affect in terms of higher susceptibility of a persistent of apical periodontitis, of a resistance of apical periodontitis to heal following endodontic treatment. And if you look at another polymorphism, a polymorphism is rank and rank ligand genes, so associated to bone resorption, are associated with lower risk of persistent apical periodontitis. So this is the other way around. Some people will have lower risk of developing apical periodontitis given the same bacterial exposure. And also microRNA can be upregulated in apical periodontitis, and so may be important in suppressing inflammation and promoting healing in apical periodontitis. So we're starting to take a look at the basic studies on the dynamics of apical periodontitis in terms of inflammation and body response, and we see that some people are predisposed to develop apical periodontitis faster, to get higher, bigger lesion, and also to heal with more difficulties, simply because of their genetics. Last but not least, the presence of a sinus tract. We know from these studies that the presence of a sinus tract reduces the odds of success by 48%. Now, why is it? More often is probably sure that sinus tract has a big problem in healing. Why? Because we have a double infection. We have the infection coming from the root canal sustaining the lesion, but also we may have an influx of bacteria from the sinus, from the oral cavity. And so it is more difficult to stop the infection. Take a look at the sinus tract. This is a nice picture that we took during an ultrasound study. You see, this is the lesion. This is a tooth number 12, following trauma. See, huge lesion. This is the lesion, and this is the sinus tract as followed by ultrasound imaging. This is the opening. And you can see this is the color Doppler. You see a high vascularity along the sinus tract, showing a high degree of inflammation. And if you look at other papers, you see new targets in predicting poor wound healing in apical periodontitis and dynamics of bone loss in cases with acute or chronic apical abscesses. We see that the negative impact that the sinus tract may have on the healing of apical periodontitis can obviously be explained by the microbiota, but also by the stronger reaction of tissue destruction, which is part of a response of these patients. So these also are patients that are highly responsive. So no wonder that it is more difficult to heal apical periodontitis when the patient presents with a sinus tract. So where do we go from here? We're obviously concentrated on clinic and shaping and obturation and doing our best, which is the essence of root canal treatment. And I won't deny this. Actually, it's the most important issue. But can we look at something else? We're always investigating. This is the last session of my talk, and it's also meant to be a little bit provocative. Can we look at therapeutic adjuncts? We had a fantastic lecture on how to better our disinfection. Now let's look at what else can we do. Of course, this is the best literature available, just for a smile. Can we really boost our immunity? Can we help the body to react to treatment? This is a very important case that I wrote. It's a case report. I published it because it was challenging. I got also the cover of a journal of endodontics. I was really flattered. And so somebody asked me what I was wearing in that circumstance. So I would have substituted this for a more flashy picture. So being serious again, 45-year-old young female, she experienced malaise, weight loss, constant low-grade fever for a while, and then she had a hard and painful swelling on the left clavicle, and also a painful swelling on the left mandible, and a back history of pustulosis. She came to the hospital. We did a scintigraphic evaluation among the others, and you could see we had hypercaptation in the left clavicle and in the left mandible. Okay. We did all of the exams, and they referred the patient to us also because she had also a mandibular problem. And I got this tooth, number 36, apical periodontitis, but interestingly, this is cavit. This tooth was undergoing the second retreatment because it started off with a deep caries. Then he developed apical periodontitis. She had symptoms. They did root canal treatment. This goes back a few years. Then she had symptoms again, so they did a second treatment. She was still in symptoms. And then they started to retreat the tooth, and that's when she came to the hospital. So I saw the patient. The diagnosis was Sappho syndrome, which is a rheumatic disease, so-called autoimmune disease. And the etiology is unknown, mostly genetic predisposition, that's what they say. And infection can be a trigger. So what happened? We did a treatment. The treatment plan was endodontic retreatment on my side and pharmacologic treatment on their side. They used biologic medication and methotrexate to treat autoimmune disease. I did root canal treatment. Guess what? She had a broken file that was broken during the secondary treatment. I couldn't do any better. I told her we'll wait and do surgery when you finish with all of those medicine. But she healed, and she healed fast. And if you look at the scintigraphic examination 6 months later, no more hypercaptation in the mandible, in the clavicle, and no more hypercaptation in the mandible. So, question arises, was the lesion the trigger to the syndrome? Or healing of the lesion was conditioned after the secondary treatment to the medication that she was given because of the immunologic disease? Because, of course, the medication were immune modulators. So I decided to look into the medication. She was given biologic medication, which are monoclonal antibodies, very specific against targets of diseases like inflammatory mediator like cytokines. These medication have the power to block inflammation, in this case, from the very initial phase, very, very specific. So I did a study, an in vivo study. I went to Loma Linda, which is my alma mater, Tora Binajad, and we designed a study to evaluate the effect of an anti-TNF alpha, which was the same medication that the patient took, in conjunction with root canal treatment. We created a model of apical periodontitis on ferrets. We treated the ferrets in 3 groups. One group, traditional root canal treatment. Group 2, together with traditional root canal treatment, we administered the anti-TNF alpha in the lesion. Group 1, we did regular root canal treatment, but we did systemic administration of the anti-TNF alpha medication. You see the CBCT, and you see also the histopathologic session that was obviously taken at the end of the study. We did recall to check on healing of a lesion. We did it every 3 weeks for 3.5 months to see not only whether the lesions were healing, but also which was the rate of healing. So we had many CBCTs, and you see from time 0 to when we stopped the experiment, the 3 groups. And we were able to see that the group which had the local administration at the apex of a lesion, together, of course, with the root canal treatment, started with the larger lesion at T1 and ended up with the smaller lesion, given that all the lesions healed or were close to healing. But I say group 2 at the smaller lesion, and also it started healing faster than the other groups, especially than the simple root canal treatment. So we hypothesized that an anti-TNF alpha could, let's say, enhance the healing process by speeding it and giving a better healing result. Obviously, if we do a correct root canal treatment, which will sustain a favorable environment. Then we had the real cases, because unfortunately, fortunately, we had real patient taking anti-TNF alpha for these rheumatic syndromes who needed root canal treatments because of apical periodontitis. And we got another cover and we were celebrating. So we wanted to see whether also the patient under immune modulators, anti-TNF alpha, would heal at the same rate of other patients, or whether better, faster, or even in a worse mode. And we had only, this is a very small study, but those were patients with a very stringent recall time, 22 teeth each. On one side, the patient with IBDs, on one side, the controls, male and females. And we measure also the periapical, the initial periapical index score. And we found that healing was already appreciable at an average of 3 months in patients with IBDs treated with anti-TNF alpha. They were a little late in the controls. So the patients who were taking the anti-TNF alpha given an endodontic treatment were healing a little faster. And that was interestingly because on the other hand, the patient taking the anti-TNF alpha were patients with autoimmune disease, but we were taking the immune modulator and also they received a good root canal treatment. Now the study is very small, but we had a fantastic control of the patient, treatment protocol, recall rate, and 2 years follow-up. So we also confirmed that the modulation of excess cytokine using the anti-TNF alpha might enhance healing of apical periodontitis. Then we look at the literature, and that is mostly on the periodontitis side, because the periodontist started before I did, checking the effects of this anti-TNF alpha, anti-interleukins, biologic medication on periodontitis. To put everything together, we found out, doing a systematic review, that biologic drugs seem to ameliorate mild to moderate periodontal inflammatory process, given that we do the treatment, probably because they interfere with too much cytokines production. Of course, if you do not treat the patient, if periodontitis or the apical periodontitis is very acute and under control, if a patient takes the immune modulator, then the result is the other way around. They can get more complications. So it's a modulator of a good system. But look at, this is the latest study by Dr. Ilan Rothstein at Southern California. And they did a huge, him and Dr. Katz did a huge study because they had very big numbers in terms of 1,000 people. This is a clinical study, hospital-based study on the prevalence of periapical abscess on patients with autoimmune disease. In this case, they had rheumatoid arthritis. You see, big abscess, and the consequence of a big abscess on an immune-compromised patient. And what they found is, of course, that the patients that are immune-compromised develop more abscess, more acute apical abscesses than patients that are not. So talking about patients with rheumatoid arthritis. The interesting thing is that among the patients with rheumatoid arthritis that were under anti-TNF alpha, it was, they had less occurrence of apical abscess when compared to the same group of patients. Of course, they still had more abscess than the group who were not immune compromised, but less than the group that was immune compromised. By this also evidentiating that anti-TNF alpha might prevent some of the worst portion of apical periodontitis. So this is a possible line. Now, let's look at other suggestions. What's going on again? Because we always concentrated on other things. Stashenko hypothesized that we may achieve an earlier resolution of the resorptive process in apical periodontitis by doing genetic therapy to modulate host response. And this is one thing. But also, it was found almost by chance that patients that take statins because of high blood pressure or because of high cholesterol seem to have a lower occurrence of apical periodontitis when compared to patients not under statins, given the same kind of patient. Why is this? Because statins have a very important anti-inflammatory and immunomodulatory property, besides their desired effect of lowering cholesterol levels. And so they may also shorten the expected healing time of apical periodontitis. Okay, what else? We did a systematic review to test this hypothesis. Can systemic administration of statins affect the healing of development and healing of apical periodontitis? Out of a number of studies, we ended up with 8 studies, and we can answer that systemic administration of statins influences the progression and the response of apical periodontitis. One more, metformin. If you look at the literature, what's coming up is that, as I said before, with the latest study of WAD on diabetic patients having more apical periodontitis, that those on metformin or statins were having a little less compared to the group of diabetic patients. So it looks like systemic administration of metformin may reduce apical periodontitis in experimental studies. Why? Because it modulates the inflammatory response and so supports healing. One last opportunity, while I'm showing you my hometown, talking about modulating inflammation. What else can we do? What if, instead of trying to limit the excessive inflammation while treating apical periodontitis, we can promote the resolution of inflammation? This is one of the newest trends in medicine, which is try to bring the tissue which is inflamed back to its homeostasis through a switch towards the synthesis of immune resolvent molecules. You know that some of the molecules will start the inflammatory process, some of them will keep the inflammatory process on, and some of them will resolve the inflammatory and move it toward the end of the process. Now, what are the pro-resolving mediators? This is a class of cell signaling molecules that are produced by the PUFAs, polyunsaturated fatty acids, which intervene in the last part of the inflammation, pushing it to resolve. And we have lipoxin, resolvins, and protectins and myrisins. And those molecules have been tried and put in relation with healing of periodontitis. What about apical periodontitis? This is our latest paper. We did a review on what do we know about the impact of using pro-resolving mediators in healing of apical periodontitis. You see, we ended up with 8 studies. And we seem to, the study showed that pro-resolving mediators tend to enhance and restore the tissue integrity due to the anti-inflammatory and pro-resolving properties. So they may be considered a possible adjunct to root canal treatment. Maybe we do root canal treatment and then we give the patient some food supplements that may help resolving the inflammatory process faster, especially in those people that are high inflammatory people, as we saw before. So where do we go from here? We saw that we have a problem with persistent apical periodontitis, even if we do a regular root canal treatment based on the state-of-the-art cleaning, shaping, and obturation, notwithstanding coronal restoration, of course. We know that patients heal at a different rate depending on how they feel, how strong they are, their immune condition. But also we know that some patients have a tendency of inflame more for a longer time and are not able to switch off the inflammatory reaction, even though they undergo a good endodontic treatment, like in other diseases. So we may have a delay in our response to our treatment because of a patient. And we saw that there are some medications that have been put into relation with a faster resolution of inflammation and of a treatment of a better outcome in the treatment of apical periodontitis. So I think we need a call for action. We have all the best so far in imaging, in materials, in devices, and of course, knowledge. Knowledge is traveling so fast. We got fantastic publication every day. It's so difficult to keep up with it. But can we take a look at medication for once and see if they can help? And talking to youngest people, let's also explore this part of endodontic treatment. I really thank you for inviting me, and I will be able to answer any question or to answer even by mail in the future.
Hello, Dr. Koti. Excellent presentation. It explains really well the variable outcomes that we see in the clinics, and I really enjoyed it. We have 3 questions. How much do you wait before you assess the success or failure of root canal treatment in medically compromised patients?
Well, usually I wait as long as possible if a lesion is not getting bigger and if the patient is asymptomatic. So I wait even years. The patient has no subjective symptom. If a patient can use the tooth and has no problems, then I will wait, especially if the root canal treatment seems fairly good.
Okay. In periapical infection with the sinus tract clinical presentation, would you recommend 2 visits root canal treatment?
Oh, yes. But simply because, well, of course, we go for one single root canal treatment, but I'm not so fast possibly, but usually when the case is complicated, when you think it's highly infected, I want to take more time and do it more carefully. So that sometimes that means that you have to re-disinfect the second time, but you also do it better. It depends very much on the difficulty of the cases, I think.
Okay. The last question is, would you recommend systemic medication instead of apical surgery in adequately treated cases with resistant infection in the future? And what are the possible side effects?
Well, that's a good question. And apical surgery is a fantastic option. You need to have a patient willing to do it. We need to be, especially for medical compromised patients, sometimes these people are not very inclined to do surgery, but it's always the first choice. I would not substitute apical surgery with a medication for one simple reason, because we don't know enough. And as you pointed out, I made some suggestions based on the research that is growing and also my personal clinical research observation, which drives me to say, let's open our mind, but we're not ready. So of course we need to outweigh the side effects of a medication with the possible positive effects. So it's an open field for the future. That's what I think. Not too far back.
Thank you, Dr. Koti, for this nice presentation.
Thank you very much.